I see a lot of kids on for bedwetting. That's one of the biggest things that I actually treat. Usually they'll range from 3 to 4, which is kind of expected, but a lot of parents like to get some treatment between that age, but the oldest is probably 22.
Today's guests are Dr. Nader Khadraga and his colleague, Dr. Mohammad El Ali, Clinical Director. With 17 years of experience, Dr. Ned has built 6 multidisciplinary allied health clinics across Australia and worked with global names. He also served as the official chiropractor for WWE during their Australian and New Zealand tour. Together, they focus on identifying and treating the root cause of pain, combining chiropractic care, rehabilitation, and performance optimization to deliver real results.
Sometimes when a child hasn't integrated the reflexes at a certain age, it can actually emanate into something else as well. For example, as simple as a kid having messy handwriting. People don't even think about that, but it's a reflex that hasn't been integrated.
So we can definitely say that bedwetting isn't just because he drank water or she drank water and slept.
Actually, it's one of the biggest misconceptions. It's got nothing to do with that. When you see children with ADHD, you need to be very careful, very sensitive in how you approach it, and there are treatments.
I've talked about this before. Like, I get plenty of toe walkers that I come and see me and I help them with toe walking, and the first question I get asked all the time is, does my child have autism?
You've did well to reach our page so far. Make sure you follow, share, subscribe, and like. We are proud to announce that we've partnered with Core Assist Disability Services. If you or anyone has a disability, you can follow and contact Core Assist, and they will go above and beyond to help you all over Australia. We've also partnered with Imperial Glass and Timber for all your timber needs. This panel, Imperial. We love Imperial. From bespoke joinery to standard joinery, they have it all.
Ladies and gentlemen, I am absolutely thrilled to have one of the early guests, a special guest, and also his colleague, and we'll talk about what you guys have done soon, but Dr. Ned and Mr. Mohammad, thank you for joining the Chronicles of Faith.
Thank you very much.
Thanks for having us.
No problem. Look, I'm going to dig right in, even though it's been far and few between since our last pod, but again, I'll never forget the early days. What have you guys done? What have you launched? Like, all of a sudden I see a moon and an emblem and a rocket ship
And a rocket,
just to the moon, right? And I'm not a kid, obviously, but the kid in me was like, whoa, I want to go there. What's going on? What have you done?
Well, pretty much what we've sort of been working on for quite a while now is we've decided to open up a pediatric clinic. We saw a lot of kids come into, ChiroKinetix, our original clinic, and we're seeing an influx of children and families there. And alhamdulillah, like, it was so great to see like all these families so happy, in our environment, but we really felt like they needed their own space.
Wow.
Yeah, the kids need a kid space, something more family friendly. And alhamdulillah, we got the opportunity to open up ChiroKinetix for kids. And we thought, what better way to send the message to the kids than help them take off on their journey. That's all the rockets you see.
Oh, that's what the rocket is.
That's what the rocket
It's a journey, their journey through their health. So when we had our pod last, we were talking about the chiropractic and physio and how you've combined them in your clinic. So I'm guessing you've done the same thing, right? ChiroKinetix for kids, chiropractic and pediatric physios.
Well, there's a lot more to it. So it's normally we're having punch ups, chiros and physios. But look, I think we've concluded that everybody definitely has their part.
Yeah, that's right.
So Mohammed is actually a doctor in physiotherapy as well. So he's highly qualified, alhamdulillah, and no better person to help run this clinic than yourself. He's a clinical director there, so he pretty much leads the team with me. And it's not just chiropractic and physiotherapy, so it's purely only for kids. So alhamdulillah, we had probably about 50% of our patients in ChiroKinetix are kids, right? So that's why we decided, okay, they definitely need their own space. Everybody will notice when they come into our clinic that it doesn't actually look medical at all, and that's on purpose. So there's no sharps bins anywhere. There's no posters, of anything medical, no medical charts or anatomy, nothing like that any kids can see.
Doesn't throw any kid off.
No. But we knew that they needed their own space, so they can run around, they can, have a laugh. The practitioners can be in their own zone as well. You'll notice that our uniforms are very different as well. very colorful, and it's amazing. It's an amazing place. But it's not just chiropractic and physiotherapy. It's probably the only clinic in Sydney that brings everything all together. So we've got, chiropractic, physiotherapy, dietitian, naturopathy, OTs, speech, behavior therapists, child psychologists, podiatrists.
But we talk about allied health for kids.
Yes.
Look no further to ChiroKinetix for kids.
I think that was also one thing that drove us a little bit, was a lot of the parents were telling us, like, especially the kids that have, like, those conditions where they need multiple therapists. They're always driving back and forth, and it was really hard to, go between clinics and between, childcares and all that to get the therapies under one roof. So I think we thought, let's bring something under one roof, make it easier for parents. And already parents have, like, been so happy with the idea that they can come in and do their, 2 therapies on
one-stop shop.
Yeah.
Okay.
So
if I have a child and they need, for example, OT or behavior and physio and perhaps a chiro, I can probably visit that one day or half a day and see all the clinicians inside, right?
Yeah.
Absolutely.
And we've actually gone beyond that as well. Okay. We've tried to even get a male and a male and a female of each discipline as well.
Oh, wow.
To try to cater, because look, sometimes it's natural that like I had a caseworker tell me yesterday, look, my child prefers a female physio, if that's okay. They know Mohammed's great, but they feel a little bit more comfortable. And I said, look no further. Within
And that's that cultural sensitivity within your niche, right?
Absolutely.
Yeah. Not even just cultural. It's just up to the kid.
That's
really
true. Yeah.
Some kids that we see like to I don't know if they feel more comfortable, or they just they're able to build a bit more of a bond with a specific type of, if it's whether it's female or male, and that's just what they feel comfortable with, and we just have to cater to that. So if we're able to do that for as many kids as we can, then I feel like we're ticking some boxes.
Well, Dr. Mohammad, you're a pediatric physio,
yes,
right? And I know many physios, but from what I know, the pediatric physios aren't common as much as a physio, right?
Correct.
So when we're looking at the pediatric side of things, what are the most common injuries or issues that parents face with their kids? I know for me, my hips. And the leg length and flat feet. Yeah. That's for me personally. So what do you challenge and tackle?
Yeah. So there's so much in peds.
You got about 3 hours?
I'm going to need
I can talk to you guys for 3 hours.
Get a pen and paper. There's so much that peds physios do. And I feel like peds physios each end up taking their own sort of niche that they further go into from like pediatrics. So you've got like, your general sort of conditions, your sort of conditions they're born with, torticollis, which is like the stiffening of the neck, club feet where their feet are turned inwards. So a lot of those sort of like plagiocephaly, which I know Ned deals with a lot.
The flathead.
The flathead, different shaped head.
And they wear a helmet sometimes, right?
It depends. That's what we says.
Yeah. And then you've got like the different sort of stuff, which is more the complex sort of disability neurological side. So that's like a lot of rare genetic conditions, cerebral palsy, like a whole heap of really like sort of complex conditions.
And this is what a pediatric physio does.
Yeah, absolutely.
Well, I know someone who's a physio, and they took their own child to a pediatric physio about the turning of the legs, I think. Or the caving in of the hips or the legs. Yeah. So rather than he treat the child, his own child, he actually, as a physio, booked a pediatric physio. Yeah,
well, there's so much like more sort of training and courses that go through, so that like anyone can see children, but doing a little bit more specialty training like allows you to see those sort of more I'd say in-depth conditions, more complex cases, and just sort of understand the pediatric musculoskeletal system a little bit better, because obviously kids they don't, like, their bones don't look like mine and yours.
That's right.
Take an x-ray of me, take an x-ray of a kid, you're going to see a whole different heap of things. You're going to see fragments everywhere in kids, but we know that they're growth plates, and there's different sort of things that happen with the growth, but that's why you get that distinguished like characteristics between a normal physio and a like more pediatric physio.
Would you say a common lower limb issue for parents that they may face with their child, maybe from birth, or they probably discover it once they start walking or delayed walking, is the curving of the legs?
Yeah, huge. I'd say anything like hip down is
hip down, lower
very,
down.
very common to see. We see hip dysplasia. It's usually picked up quite early, like after birth, but it can be missed sometimes where regular checks are done. But we see a lot of like hip pathologies, so hip dysplasias, in-turning, out-turning. Same with the knees.
Yeah.
We see like a bow leg, or they call it bow leg.
Bow leg, that's right.
Bow leg, or knock knees the other way around. And then even working your way further down into the ankle. So many different pathologies, but they all sort of link together. It's like a big chain. They all sort of are linked together.
From the top, bottom up?
From bottom down.
Bottom,
but as well, the bottom up can be affected as well. Yeah.
Okay.
Yeah.
And what do you say? What do you say to those who maybe are reluctant to take a child due to a misconception or myth, or it's probably taboo that a 1-year-old goes to see a physio because they'll grow out of it? What do you say to that?
Yeah, look, I get so many questions, so many times parents come and see me and they'll be referred to by like a doctor, and they come to me and they say, the doctor told me to come here, but I've got no idea what I'm doing here. Like, don't you treat back pain? I say, well, I can, but it's not what I do here. So I think like parental education and just like general like education to parents and families and caregivers, and even to like doctors and specialists themselves, it's good for them to understand that there's so many checks can be done early on to avoid later pathologies and later treatments that can be a little bit harder to work on down the track. So it's always it's very friendly at the start. It's more honestly, the first session I spend probably about 3/4 of the session just chatting to parents, understanding GA history,
education.
And then I do a little bit of assessment for the kids. It can be functional, it can be just observing, or it can be even getting out my rulers and my my equipment and measuring angles and all that sort of stuff
without them realizing.
So all of it is play based, so the kid they have probably no idea what they're doing, but it's all just fun and games to them. We're looking at them through x-ray vision,
just like lower primary education, learn through play. You have treat through play.
Absolutely,
I guess.
Absolutely.
So it's interesting how we come about it. So for example, like I see a lot of kids on for bedwetting. That's one of the biggest things that I actually treat
kids bedwetting.
So
please go into that.
It's my youngest. Well, usually they'll range from 3 to 4, so which is kind of expected, but a lot of parents like to get some treatment between that age. But the oldest is probably 22. But when the average would be probably a boy. I'd say maybe 10 years old, between 10 and 12. That would be my average, where they'll have issues, and they're the ones that, for example, they get, worried about going to camp or sleeping over their cousin's house, or, for example, they have to be in a nappy, or very embarrassed. There's a lot of research behind it. There's continued research, obviously, and a lot of parents would vouch for, chiropractic in terms of, it's all, and a lot of it is anecdotal evidence as well. Anecdotal meaning, what we see in the clinic. So for example, I tried something on, say 50 patients, and 35 of them got better because of this type of treatment. That's called anecdotal evidence.
Would that be the same as evidence-based?
So no, look, that's obviously that's a particular type of evidence. So that's why they call it anecdotal evidence. But then there's obviously from research papers and things which should be kind of depending on how many cases there are. So the more cases you have, the better it is. And randomized controlled trials, and obviously the bigger the case numbers are, the better it is.
You love your research papers, eh?
Look, I do. So especially like in our industry, you always have to be on top of things. Yeah, definitely.
So if we go back to bedwetting, how do you, what form of intervention do you provide for a child, for example, the age of 10?
Yeah. So, and this is what I was trying to talk about before was, so there's a whole series of assessments that I'll do. So I try to focus on the nervous system, right? So there's a lot, talking to the parents, does a child have anxiety? We try to figure it out without being too oversensitive, or trying to cause any, trying to look at any misconceptions or anything like that, but also trying to be, stable with our questioning, because it has a lot to do with trauma as well. Okay. So, but when it's, purely nervous system based, we can dive into it. And as you know, the spine controls the whole nervous system from the brain all the way down. And what we look at are any interferences pretty much from the neck all the way down to the sacrum, which is pretty much just where your tailbone is. And nerves control everything. Pretty much everything nearly everything in your body. So look, it's probably a topic on its own, but yeah, we do treat a lot of that. And I do find that when I do my assessments and I'm treating them, sometimes I'll get onto like a little bump where I feel like, okay, this child is not improving the way they've improved, but probably not, instead of say bedwetting every day, now they're bedwetting once a week, but they'll stay like that probably for a couple of months. And that's where I'll be like, okay, Mo, I need you to do a full assessment on their reflexes with me. So I've done an assessment on all that already, but he has his own way of doing the assessment. He has a big gym. That's what this clinic is.
So you refer as a chiro to your pediatric physio?
Of course.
Oh, wow.
You know, so, and then that's what I'm saying. So he's got his own big gym in there, and it's all set up. It looks like a kid's play center, right?
Yeah, I've seen the videos.
But it's very specific, you know, and, you know, I ask him, I go, would you mind double checking these reflexes, making sure, you know, they're, you know, so not everybody has reflexes that they should have. Some kids are born with reflexes, but they should diminish by a certain age as well.
That's why they assess them as a newborn. Or, through those milestones to test the reflexes, right?
Yeah, and then some reflexes should leave as well. And they're called that's what we call integrating reflexes. Sometimes when a child hasn't integrated the reflexes at a certain age, it can actually, you know, emanate into something else as well. You know, or for example, as simple as a kid having messy handwriting. Yeah, people don't even think about that, but it's a reflex, right? Yeah, it's a reflex that hasn't been integrated. So,
what about grip strength? Does that play a role with messy handwriting?
2 words that'll change the way you deal with pain forever: physio, motion. Where Mo really puts you back into motion. You've heard about the infamous knee reconstruction that I've had, the chronic back pain that I've had, and one man helped me go back into motion. Not just that, helped me go back to playing sport when I thought I needed surgery. His name? Physio Motion. Contact him now and mention Chronicles of Faith podcast, and he will ensure that he gives you a tailored program that suits your needs. Don't feel like you're alone with the rehab, whether it's post-surgery, pre-surgery, back pain, lower leg pain, any type of muscle pain. Physio Motion will get you back into motion.
Well, that's one of the reflexes that we try to look at. Not grip strength, but it's more just, you know, the palmar.
Yeah, I think that also talks a little bit to what the OTs work on.
Correct.
A lot, yeah. So I was actually having a chat with the OT about bedwetting the other day, and that's also something that they work on it also in like a different way too, which was so surprising because
a different take.
So they also look at it through what we also would look at, like core strength and things like that. They also look at like timing and things like that throughout the days. There's a lot of research to back that sort of intervention alongside all the other interventions, which is really interesting to see.
I feel like bedwetting is a topic on its own.
Oh yeah.
And I didn't, prior to this pod, I didn't associate bedwetting with what you guys do.
Yeah, we see that many bedwetting. I swear, I think we can open a clinic just for bedwetting. No, we won't do that, but we do see a lot.
Is it very common?
Look, it's more common than what you think. And when the child comes in, I always speak to the child. I try not to speak to the parent. You know, which is amazing actually. So they feel really comfortable straight away.
They connect, right?
Straight away. You know, you need to know how to read the energy in the room.
That's true.
And we have a little chat with the parents sometimes beforehand. We have a little bit of paperwork which they tell us about, obviously what they're worried about, and there's a way of doing it.
And if I go ADHD in young kids, it's on the rise. It's not as common as when I was young. Some say that it's maybe wasn't diagnosed or undiagnosed back then. But the rates, in my opinion, and a humble opinion, are skyrocketing, right? Especially as I see them firsthand from an education background. How do you, as a chiro and a doctor and a pediatric doctor, treat ADHD in a child? Or is there any form of treatment to assist a child who has been diagnosed with ADHD?
The reason why we say, look, these topics are very controversial.
That's it. I appreciate that disclosure.
And by all means, you know, I hope that nobody gets offended with any of our, you know, any of these talks. And it's not meant to be offensive. It's always meant to be an open discussion.
That's true.
Okay. One thing that I've always learned is ADHD should never just be thrown out there. And you see it a lot. Yeah, it's okay. Like, you know, between adults, sometimes they muck around. Oh, look, you know, I've got ADHD.
Yeah.
You know, that's okay. That's fine. You know, I think if you're mucking around between each other, but when someone you don't know, or, you know, they've got kids, you know, so that parent might have someone with severe ADHD, and trust me, it affects their lifestyle a lot.
Yeah.
Hey, lifestyle.
Yeah.
You know, there's obviously there's a spectrum of types of ADHD, but when you see children with ADHD, you need to be very careful, very sensitive in how you approach it. And there are treatments. Okay. And I think one of the, you know, we got, you know, Sakina, who's been with us for a while, and she's one of the most well-known naturopaths as well. So she treats a lot of kids, and she goes through that natural pathway, and we get a lot of pediatricians referring to her within our clinic just for things like that.
And she treats, she works as well as in the ChiroKinetix for kids.
Correct.
Mashallah.
So she's there as well. But like, for example, you know, what would you, if someone came in, say, a parent, and they thought that their kid had ADHD, but they're denying it.
Yeah.
Right?
Yeah. Now, I think, like, to add to what Ned was saying, even just generally about like the terms of ADHD and things like that, I think I personally feel quite strongly about this topic because I see firsthand, you know, in clinic and in childcares and all that sort of stuff, what you know, ADHD really truly looks like, and even things like OCD with kids. I think we also throw the term
about that over dinner.
we throw the term out, like OCD a lot, like, oh, I have OCD, you know.
Yeah, loosely.
We use it very loosely, and unfortunately there's even like bigger terms that are thrown around loosely, even like autism is thrown around quite loosely.
It is.
And when you see it firsthand with children who are, you know, experiencing or have that like neurodiversity, it's a very, very tough thing to just be throwing it out there about parents. I think if there's concerns and true concerns, I think that's when they should seek that medical, you know, opinion. There's tests that can be done, and it doesn't necessarily have to be like daunting tests, like blood tests and things like that. Like, it's more like, you know, IQ tests, things that, like, you know, function tests, a lot of that stuff that help us, or help, you know, us and the medical practitioners come to a bit more of an understanding of what's going on. Because a lot of the time it doesn't have to be like autism or ADHD. Like, I get a lot of toe walkers. I've talked about this before. Like, I get plenty of toe walkers that I come and see me, and I help them with toe walking. And the first question I get asked all the time is, oh, does my child have autism? I tell them, well, I can't diagnose.
I just got goosebumps because I had a child a couple of years ago. He was in year 2, and he would toe walk, and I flagged that to the parent from a welfare point of view.
Yeah.
And the response was, does my child have autism? Yeah,
it's like probably the first question I get asked, even with delays, like, you know, with crawling delays or walking delays, I get told, does my child have autism, or does my child, you know, what's going on? And we say, like, we really need to dig deeper to understand what's going on, because like toe walking can come from so many things, and it can come from nothing. Like, the whole diagnosis of toe walking is called idiopathic toe walking, which means toe walking with no reason. There's no medical reason to it. You know, we see toe walkers that come from like a sensory based thing, which is a lot what we see in ASD, or like tightness in the calves, which we see in neuro conditions. But there's also just toe walkers there,
where they just like to walk on the toes.
Yeah, so we can't really like look into their brain and see what's happening, but there's like ways that we can sort of work around it. But it's hard to put your finger on, oh, this is definitely autism, when, okay, it's just toe walking with nothing else surrounding it.
Well, toddlers around the age of 2, right? Many toddlers run confidently at that age, or jog. To them, it's running. Is it normal for them to experiment by toe walking for a certain period of time and then walk normal? They transition themselves? Yeah,
so I see a lot of early walkers, or even just general sort of in that time frame, like walkers that go up onto their toes straight away. And it's quite common, like you see a lot more, and it is sort of an early typical variance in that walking, but it depends on how often they're doing it. So if they're doing it like over like 60% of the time of their walk, then I'd say, okay, let's start monitoring. Over 70%, I'm like, oh, we got to look into this a bit more. It's starting we're starting to get a bit curious as to what's going on. Further 80, 90%, then we're like, okay, we need to understand what's going on, because then it may affect their biomechanics of how their foot bones develop as they get older. So that's how I would sort of look about it and think about monitoring it.
The chiropractic throw on this is, have you heard of what a jolly jumper is?
Yeah, that was my next question.
Jolly jumper, baby walker.
But I was just going to ask you, what's your take on the baby walker? I spoke to an orthopedic surgeon from Saudi. He tried to work here years ago, didn't work out, long story. He came in for a visit and I told him, what's your take on a baby walker?
Yeah.
He said, throw it away. That's what he said.
Yeah.
He's an orthopedic surgeon, knee reconstructions, as you know, shoulder reconstructions. Yeah. He said, throw it out. Yeah. And then there were old school, older generation in the room said, my children were all on the baby walker.
Yeah.
What's your take?
I think that's the one thing we agree on all the time.
No, look, so I'm always, like you'll see me in some of my old videos also, where I go into, say, baby bunting, and I actually do reviews on.
Oh, wow.
So, there's one coming up soon. I'm doing it with a couple of people, So, try out all the new toys, because it could mean, the
restraint, the chest held baby hold, whatever it's called. Yeah. We were talking about it the other day.
Yeah.
I know one's called a baby born, but that's as far as you can get me.
But the same idea where the hips flare out, right?
Yeah. But for example, say a jolly jumper, obviously they're supposed to be a certain amount off the floor, and then they're supposed to just kind of touch it with their toes enough that they can bounce off with their toes, right? What muscle is activating just to do that?
Calves.
Of course.
Yeah.
And with a baby that doesn't even walk yet, look, it's okay to randomly do it, but if you're putting it there to, make, tanjot water for the day, or, keep him in there for a couple of hours, they're obviously going to be activating their calves for a very long time. Now, for that age, they become, really strong, which is not a good thing.
Whoa.
Okay, so, and that affects obviously the way they crawl, and that's one of the best things that Mohammed does as well. He assesses the way they crawl, tries to understand what's happening and how we change it straight away, because there's only a certain amount of period that they crawl for, which they should crawl, and then they start walking, but they should crawl properly as well before they walk. But come to the whole, the calves tightening up really strongly during a jolly jumper or a walker. So walker is the same concept, right? It just means that they're walking around, but their calves are still doing that. So how aren't they going to be toe walkers, at least for the beginning of their walking life, right?
Yeah.
Hopefully enough that, they're wearing good shoe wear and all that, then they kind of get out of that. Okay. But that's where, the whole idiopathic thing comes into it, where it's like, no, okay, so we've assessed them, they don't have autism, but he's a toe walker. But did you tell us about, how you put him in the walker for 3 hours a day?
Do they admit it?
Look, we don't throw things like
there's also no blame,
it's helping the child, but there's full disclosure once they realize, okay, we've ticked all this off.
Yeah, most parents are really good like that.
The light bulb moment, I had him in the walker.
Yeah. There's no such thing as about blame. Like, we're not saying, you did this. No. It's just, how do we fix this? And let's go forward. So one of the signs and symptoms, that your child may have autism is a toe walker, but it doesn't mean you've actually got autism if you're a toe walker. If that makes sense. But yeah, so then that's coming back to about the whole idiopathic thing. So that's only one of the reasons, for example. There's so much
more. Even for like baby walkers.
Yeah.
They are probably my I can't even look at one.
So you throw it away?
Yeah, absolutely. It just really forces...
I won't, because I'm realistic. I'd say 20 minutes is fine.
Okay.
Look, I get that. But at the same time, for me, I just think about the way the hips sit in a baby walker forces it into a very unpreferred position. They're very outward turned, very not unideal. And for sitting in the unideal position for a very long time, you are risking a different hip sort of pathologies or development in an unpreferred, unlikely way. So we really want the hip to develop in a really in that really ball and socket, we call it. It sits nice and tight inside, nice and firm. But we see a lot of the time with baby walkers, they start to develop more of like a shallow edge. And it's just going to create more of that shallow edge out, and then hopefully not. But sometimes we have seen like dislocations and stuff over a very prolonged period of use.
How old would the baby or child be for a dislocation from a baby walker?
Well, if there's histories of like hip pathologies and hip dysplasias and so on, and they are in that walker, then that's going to also lead to hip dislocation. Hip dislocations can happen from like newborns, depending on how far,
Speaking of hip dislocation, we have a common theme of grandparents, perhaps, and maybe parents, where they go to lift the toddler from the ground and they'll pull the toddler from the arms. Like, it frightens me, right? And some might say, oh, relax, you're being soft, right? But then I see when you randomly scroll some videos where the shoulder is out of the socket just from pulling up by the arms. So,
you get the elbow popping off, any of those.
It can happen. It can happen a lot. Again, like there's
a hit and miss.
There's always like a discrepancy where, it's generally kids are they're quite strong. They're a lot stronger than we think. But then again, there's always that. What about if there is something underlying in the shoulder that we can't see, and then we pull them, and then that's where it happens. And we're like, oh, okay, well, we didn't know that they had now their shoulders dislocated.
Wow. Yeah. What are some of the success stories you've had? I know you were treating kids in your previous clinic, but since opening the new clinic, it's probably been enough time to share some success stories where you've seen parents so elated and happy with the change that they had in their child, or a concern, and then after a period of time, and alhamdulillah, through your intervention, have you seen the results?
I look at there's alhamdulillah, there's been many, which is like a good thing. I think that's also one of the most rewarding things about pediatrics is that although there is a lot of, I don't want to say sadness, but there is a lot of that emotional, weight that comes with treating kids. But there's also a lot of happy moments. Like, we have some kids that we've been, I see a lot of like late walkers, late crawlers, late sitters. And you've been working on them for like 6 weeks just to get them to crawl. And they come into the clinic and they're in the weight room, come out of your room and you find them crawling.
Oh, mashallah.
And like, that is like one, huge thing. Or even like just the other day, there's one little girl we've been trying to focus on walking. She's got some other medical pathologies, and we were trying to just get her to take some steps, some independent steps. And we've been practicing. It's been very difficult, and the other day in session, funny enough, she just gets up and takes about 20 steps. And like, that was like, we freaked out. Like, me, dad, everyone that was in the room was just like over the moon. So those are like the little sort of things, especially with the babies. But then you've got the larger stories where you've got like kids with like neurological conditions and they've got tightness in their calves, for example. And then you work with them and you do some casting. So you do rounds of casting for like 6 weeks, hard process, 6 weeks. You've got to cast every week that you're changing, every day in, day out. Most of them are like older kids, early young teenagers that want to walk. They can't walk. But they've been on their toes for so long because they've got those tight calves. And then 6 weeks after the casting, you measure their ankles and here they are, landing with their heels and taking steps on their heels, which is like, you've just helped someone reduce risk of falling, get them moving a bit better, have them walking with, a better movement, walking pattern. And those are the things that just make every single day worth it.
Wow.
Yeah.
What about you?
Bedwetting.
I was going to say.
Definitely.
I've known you for a while, and I had no idea that you treat bedwetting. Education's so important.
Yeah, look, there's a lot out there that, and I think because I see a lot of adults as well, there's so many different topics to talk about. But yeah, definitely bedwetting is.
You've taken me back to my childhood. I knew so many people that camped.
Yeah,
that would bedwet, and we just thought as they get older, it'll stop. That's all we knew back then.
Yeah.
And now there's intervention for bedwetting.
Definitely. Like, it's and there's protocol that I go off as well. So, and you're saying like, what are some of the success stories? And alhamdulillah, there's a lot of really good success stories with bedwetting, and the ones that aren't successful, like, we're really realistic as well. Like, we try to follow through with every single one. And even the ones that aren't successful, we try to, direct them into, okay, so now that we've done this is now the next step. for example, then they'll tell us what they've tried, the bill and, all this, what supplements. So we take everything into consideration when they're seeing us. And that way we're going to try to give them an answer. Even to the point where we talk about, mouth breathing and, we talk to the dentist with them, it's a very overall type of...
Mouth breathing linked to bedwetting?
There's a lot of links.
There is a lot of links.
There's definitely a lot of links.
Is on mouth breathing in children, is that a big major red flag? If they're a severe mouth breather?
I wouldn't call it a red flag. It's it does come with a lot of its own issues. Okay. Simply put, even just like tension, everything in the jaw. But then they could say, okay, then they got tonsillitis all the time, or they got big adenoids. But then they go to the ENT and they're just like, no, he's got big adenoids, but he hasn't got sleep apnea. So he's not really. But then why is he tired throughout the day? Why is he doing this? But then why is he bedwetting so much at night? But then when I take him through the whole journey, and then I start to notice that he's so tired throughout the day, and when he goes into nighttime, you know what REM sleep is?
Yeah.
I'm not sure if you, So, for example, everybody's nervous system is supposed to be regulated in a nice pattern. Okay, a couple of REM sleeps every couple of hours. That's why they try to say with your child, before you go to sleep, don't just put them to sleep. Look, let's play around with them for about 3-4 minutes. Regulate their nervous system. It's really good actually to do that. Do backflips, muck around with them on the bed.
Yeah.
It's really good for all that to regulate. But I'm not talking about stimulation. Stimulation is different.
It's very fine line, right?
Definitely. And once, like let's just say someone does have, say, sleep apnea, or they're mouth breathers and they're getting really tired throughout the day because not enough oxygen is happening throughout the night. And come nighttime, they're that tired that they fall straight into REM sleep. And their subconscious can't even wake them up.
Wow.
Because, their blood is getting full, can't wake them up, and they're weeing.
Wow.
And some parents tell me sometimes it's 5-6 times a night. So it's not just once. They're that deep sleeping that they can't control. They're just like, Haran, he's sleeping a lot. But there's an issue with why he's sleeping so deeply. That's not also a good thing. So that's when I recommend specific supplements on how we calm down the nervous system before they go to sleep. There's a certain, people can talk to me on inbox if they like, about things like that, where I can actually prescribe certain supplements and where it calms down the nervous system, say 1 to 2 hours beforehand. So that way, when they are going to sleep, it's all nice and, regulated. And that way, when they are filling up, and obviously I'm making sure that their nervous system, there's no interferences in the neck by making sure the spine's fine, that they're waking up in that moment. Like it's like a dolphin, it's like half their brain's asleep, but half of it is awake in case a predator comes. And they're great regulators like that, so humans have to be like that as well.
So we can definitely say that bedwetting isn't just because the good old he drank water or she drank water and slept.
Actually, it's actually one of the biggest misconceptions. It's got nothing to do with that. I can have someone that doesn't drink water 4 hours before they go to sleep and they'll bedwet 3-4 times.
Yeah. Remember when we were young, they drink water before you sleep. Wow.
Look, if you have a lot of batik, you're guaranteed for your bedwetting.
Wow. That bedwetting, I did not see that coming.
Yep.
So matami batik.
And obviously don't watch all these scary movies. And probably the most important thing is don't have a fight before you go to bed. Not about don't have a fight, only, but it's try to make sure that the child goes to bed understanding if something's happened, why you're upset with them, or why, try to problem solve the issues and anxiety before they go to sleep each night. There's a lot of posts coming up about all this, and I dive into all this about how you can help your child
regulate prior to going to sleep.
I think sensory and regulation is a whole topic on its own. Like that's probably one of the biggest things also that parents come in and see us. And not just see us for to treat, it's more just come in questioning, why is my child doing this? What's going on? And a lot of it is regulation, but it's not recognized. And it's so common because the sensory system in its own is a very unique system. It's like, if I was to go into it, pretty much you've got all your senses, and you've got a lot of senses that we can't see, like from the outside. So it's not just like your eyes; it's where your eyes take you. It's not just your ears; it's where your ears go inside in your brain, things like that. So there's different thresholds for where that sensory creates, or where that stimulus creates like a sensory, like a neuro pathway or a neurostimulus or whatever. So there's some kids that have pathways are thresholds that are a little bit higher, and some kids that have thresholds that are a little bit lower.
And that's for assessment.
So that's where like OTs really come in handy, because they are absolutely excellent at sensory regulation and sensory assessment. It's all sort of parent answered and parent questions that we sort of are able to understand their sensory needs a bit more. But those thresholds, so if, for example, for Ned, let's say me and Ned have different thresholds, it might just take him a little bit of, visual stimulus to hit that threshold and get that response in his brain. But for me, I might need, 10 times that visual stimulus to get that threshold in my brain to get that neuro response.
And that's where we go back to your gym, right? The kids' gym.
Yeah. So there's a lot of
different gyms.
Yeah.
Oh, okay.
Each room is pretty specific.
Yeah. And we really like to cater to their sensory needs. So whether it's visual, where some kids like having all the lights on and like having all the blinds open, but then there's sometimes where I've got to dim down the colors in the room, dim down the lights, and so on. Even like hearing, sometimes I've got to, we've got to get earmuffs on some kids to help bringing down that stimulus. Even a lot of like rocking. So you see a lot of kids, especially those with increased sensory needs, you see them rocking a lot. So you'll see back and forth, you'll see spinning, you'll see running around a lot. A lot of that is also just stimulus that they need into their brain to help them regulate. So we have to put that into our intervention. We can't avoid it. So if I know that one of the kids that I see, needs to run to regulate himself, I can't say there's no running or session. I need to, allocate time throughout my session to run. And most of the time I have to run with him or run with her. So it's lots of fun when you walk in, you see chaos, but it's fun.
Do you work with schools as well in terms of the behavior plans, or a plan that's tailored for an individual child where they might have learning difficulties, but maybe they're not regulating, and maybe there's high sensory needs?
Absolutely.
Do you collaborate with those schools directly or via the parents?
Yeah, no, definitely. We definitely go through with parents and with schools, even with childcares a lot of the time. So a lot of kids like have different needs or have, special things that we need to consider for them. So and they spend, how many hours of the day at school. That's where they're getting a lot of time there. So we need to be clear with teachers. Okay, Miss or Mister, we need you to please, this child has this. We need you to be able to provide this during the session. We need you to allow them to have 15 minutes of their own regulatory time, be it through this. And obviously there's so much to it. Like a teacher just can't let, one of the kids run around in the room. As you know, there's a lot,
definitely.
So that's when we've got to go higher up. We've got to speak to teachers, but we've also got to speak, to executives in the school and the department. Department can help with getting funding for support staff and so on and so forth when the child has those needs.
Wow.
Yeah. So it's big. It's big. I say a lot of our work, especially in pediatrics, a third of it is admin work. A third of it is it's not just all face to face. There's parent stuff, there's school stuff, there's NDIS stuff. NDIS is probably 3/4 of my job.
And now we have the new Thriving
Kids. It's sort of a little bit on the down low now. We're not getting much information from at the moment.
It's just been announced, and that's it.
But we're looking forward to seeing, what's going on. Early intervention, the research shows early intervention is what's key.
So I have a saying, it's not my saying, through research and whatnot for kids, that early intervention is the best prevention.
That's right.
Do we also say that in terms of your field as a chiro and a pediatric doctor?
Yeah, look, it's 100%. Okay, so one important question that I always get, and I think we're always going to have that. You'll probably get some parents asking you, but how do I know who to send them to? Dave, let's just say someone wants to come into this kids clinic. All right, my son has bedwetting. I just heard Dr. Ned does this. Dr. Mo does this. And then he just mentioned that the OT does it as well.
It's so nice.
Yeah, so look, it's funny thing is we actually all work together and we all know what each person does.
Nice.
So it doesn't matter who you see at the start, at least for the initial assessment. They will refer within the circle for the most appropriate and the most efficient.
Yeah.
You know, we're not just who's going to be the best at it, but probably who's going to be the quickest at getting the result as well. And
Depending on our child.
yeah, exactly. And sometimes you'll see us working together, maybe two as a team, one, just depending on what the problem is. And so that's at least for all the parents out there. At least just bring your child in and just get them, you know, assessed and just talk about anything you want.
Well, if I have a child, before I wrap up the pod, how can I contact you and where can I visit you for those who are from Sydney or abroad?
Yeah. So Monkey Mania, Bankstown Sports Club.
Yes.
Right across the road. So we're under the masala there. And it's called ChiroKinetix for kids. Okay. So purely for kids. It's right next to our, for kids.
Number 4 kids.
So it's right next to our ChiroKinetix clinic as well. So it's probably a 30-40 meter walk.
And your Instagram handles?
So ChiroKinetix for kids. You know, and
for kids.
Yeah.
We always have to make that clear because we get FOI and I'm like, oh, it's not going to come up.
So we're on most platforms, you know, TikTok, Insta.
Yeah. And how responsive are you with your social media for those who have queries?
I think we're pretty good.
Yeah, I think so too. Look, we're always happy to chat to parents. You know, it can be very daunting for parents to think, and it just because you know, we don't say, oh, you need to, you know, book straight away to just be able to say hi to us. We try our absolute best to answer phones ourselves, you know, and take calls and have, you know, like a quick chat with parents. And then if we feel like, okay, they're going to benefit, we'll be like, okay, look, come in, let's have a proper chat.
Consultation.
Things like that. Yeah. So we're always happy to chat to parents and even like through socials and
as
stuff.
clinicians,
can reach out. Yeah.
You know, so it's not just the admin, like you want to talk to a clinician. Yeah, sure.
Wow.
You have to make an appointment.
Yeah, you don't have to.
No, you don't have to. And if, you know, if it feels necessary, then we'll be like, yeah, sure, bring me.
Well,
you know?
Thank you for joining the Chronicles of Faith, and I look forward to bringing my kids to ChiroKinetix